So one common thing, so a lot of us, this can happen when we work out or something like that. This could get boosted up. But also, too, if you go to higher altitudes, I've talked about this before, there's a change in pressure and there's less oxygen at higher altitudes. And so you'll notice the first few days you go to high altitude, especially if you haven't been ever or never been in a long time, you might be breathing like a little bit hard walking upstairs and you're like, what? I'm in great shape. Man, most of us, I don't know, I'm not in great shape, but I get out of breath walking upstairs now. So, but you see my point is, the point is if I go to higher altitude, it's going to take a minute. Erythropoietin gets kicked in because there's lack of oxygen flowing. And then you're going to kick up and make some more red blood cells. That's the process. So the big take home is kind of what I've highlighted is how do red blood cells get made? Well, they have to have this hormone from the kidneys called EPO, erythropoietin. And that causes erythropoiesis. And that's where we get that hemopoiesis. We get that poiesis thing, that synthesis of new red blood cells stimulates from this poietin hormone, basically. That's why they call it hemopoiesis or they call it erythropoiesis. It comes from this poietin nonsense, this hormone. So the goal is, again, make more red blood cells depending on what's going on. Typically, it can depend. We can tell our red blood cells. We can tell our blood cells to do one thing or another. We can say, hey, I paused you. Stop it. And remember, too, red blood cells, the point they're making here, too, is that we're always making new ones because they don't have what? What are they red blood cells missing? A nucleus. So it means they can't divide. They can't mitosis. So they're kind of made to exert one life. Again, the book doesn't do a great job explaining why that is, but my theory would be that red blood cells are used so highly that they get worn out pretty quick, and it only makes sense that we don't want them to split and divide. We want them just to live and then die and then move on. Hey, no, not today. Wednesday for me. Yes, sir.
At that point, they die, break up, and are consumed by phagocytic cells in the spleen and the liver. Every second, about 2.5 million red blood cells are destroyed. Consequently, the body must constantly produce new red blood cells, or erythrocytes, to maintain homeostasis. The process of producing new erythrocytes, called erythropoiesis, is maintained through a negative feedback loop. The process begins when oxygen levels decline, as damaged red blood cells are removed from circulation. The kidneys detect the declining levels of oxygen and respond by secreting a hormone called erythropoietin, or EPO. EPO stimulates the red bone marrow to begin the process of creating new erythrocytes. An immature form of an erythrocyte, called a reticulocyte, is released into circulation. After 1 to 2 days, the reticulocyte becomes a mature erythrocyte. As the number of red blood cells increases, oxygen levels rise. Less EPO is produced, and red blood cell production declines.
This is also why, so it doesn't really matter that you know it's the immature red blood cells or reticulocytes. That's kind of a minor thing, but this process does take time. They're just letting you know that the reason they make the point in the video is this is why, again, if you went to high altitude, you're probably going to be short of breath and feel kind of crummy the first day. But by the second and third day, you start to get a little bit used to it. And trust me, I know this is anecdotal evidence, but I've been skiing a lot in my life and been to the Rockies and sort of stuff. And I've been to the Alps in Europe and stuff like that. And so it takes time to get used to that. Like the difference between staying in valleys of Germany or valleys in Austria and Alps is like several thousand, elevation difference, and you feel way different. It takes time, like a day or two before you can adjust. And a lot of it I would anticipate is because of this. You got to build up some red blood cells. So that's kind of how we make them. And again, it depends. You're going to make more. You're going to be, EPO is going to be produced if you work out. This is why working out or doing cardio, I know kind of a lot of us aren't going to like cardio, but doing cardio is going to cause your oxygen demand to increase, which then kind of kicks this off and is just a good healthy thing to do every once in a while. I'm kind of jumping around. What am I jumping around for? I'll come back to that slide. On page 280, it talks about breaking down red blood cells. So that's the job of the liver, which the liver has so many jobs. Does anyone remember? We've only talked about the liver slightly, but does anyone remember what the liver does for homeostasis and glucose? What does it do? Yeah, stores glycogen. Remember that insulin tells it to store some glucose in the form of glycogen, and then we need glucagon when our blood sugar is low for the liver to release some more, release it back in the bloodstream. So helps with glucose homeostasis, but a lot of stuff. Huge in our diet stuff too. Huge in helping us digest fat, so we'll talk about that. But they destroy old red blood cells. So the guy that helps us make new, kidneys with EPO, got it? Okay, shorten that. The guy that helps us break down the old ones, again, when the red blood cells get old and decrepit, they might break apart, but we don't want them to be in irregular shape. We want our red blood cell to be strong, smooth, good shape, because as soon as they start getting old and decrepit in weird shapes, they start causing blood clots and stuff like that. So as soon as they get that, and all blood's going to make a bypass through the liver because of the hepatic portal system, so eventually blood's going to pass through the liver, just like it all going to pass through the kidneys. And when it does, the liver says, "Hey, let me fix some of this. You got an old guy. We got to take him out back. Get rid of." Just say, that's how I want to go. Don't put me in a nursing home. I won't be like a horse. I'm lame. Just take me out back. I'm serious. I would rather have that. If I could write that in a will, I would do it, dude. I don't want to be in the nursing home having someone wipe my butt. Put me out, man. I think most men want to go out of that. People want to die in their bed softly. Most men want to go out with a sword in their hand. You know what I'm saying? Fighting for something. I'm just saying. I don't want to go out like that. So, hemoglobin. Remember the components of what hemoglobin was. It was some globin, which is a protein. Amino acids are proteins. Protein is just a more complex chain of amino acids. That's it. And then heme is iron, mostly, but it is this one component that's a nice rabbit trail for us. So I talk about this again with digestion, but it's a really nice to know note right now, and it's going to come up again with digestion. This guy, heme is made of iron, but this, bilirubin. Has anyone ever heard of bilirubin before? Probably. What have you heard of it related to? So bilirubin is what they call a bile pigment, but it's a pigment, an orangey, it's a yellowish pigment. But what bilirubin does is kind of help with the color of hemoglobin, but bilirubin is one of those byproducts that's part of kind of everything. So usually in this process, basically the liver just takes down these components, strips them back down to their base components so we can recycle them, right? So we can take this iron, we can take the protein that made up the globins and remake it. Go back to bone marrow and let bone marrow, right, put this back together in the form of a red blood cell and ship it back out. That's the goal. The liver says, hey, let me break down the stuff so you can put together a new red blood cell molecule and keep that going. The reason I'm highlighting the bilirubin is usually it gets put into what's called bile in our liver. We're going to talk about all in chapter 21. And gets out, helps us with digestion, ends up going out the digestive tract. Usually in stool is where it should be. We'll talk about bilirubin more, but bilirubin is actually what gives stool a brownish color, actually. So if you have no bilirubin, if you weren't making bilirubin or there was a blockage causing no bilirubin, your stool would be white. That's kind of wild, isn't it? So this is a main component of usually waste, but it helps us do something. Helps us with digestion, but mainly it's supposed to be waste product, okay? The reason jaundice happens, jaundice is a yellowish hue of the skin and the whites of the eye, the sclera. Jaundice happens because there's too much bilirubin. If there's too much bilirubin, it ends up in the bloodstream, and that's going to make you look orange, okay? We don't want that. We want it in stool and out into the toilet. That's where it's supposed to go. So just as it's a really, really hardcore nice to know that whenever our liver breaks down the red blood cells to recycle them for use, one of the byproducts of this is bilirubin, which we use in digestion, okay? But for whatever reason, if there ends up being too much, it's going to leak into the bloodstream and it's going to cause jaundice, which is the yellowish hue of skin and stuff like that. And usually jaundice is always an indicator of liver issues. That's usually what we indicate. the liver's not functioning correctly. There's a blockage somewhere. Something's going on with the liver or somewhere subsidiary of the liver, some connection to the liver. I'm trying to think, again, trying to shorthand this at this point, where we're going to talk about jaundice and the liver and bile again in chapter 21. So I'm not making it a big highlight, but it is worthy to know that where does bilirubin really come from? Well, bilirubin is like a byproduct of breaking down heme. When we break it down, that's how chemicals kind of are sometimes. There's always going to be like, you put two chemicals together, you make a new solution that does something. But when you break that chemical back down, sometimes byproducts happen. Products that weren't there originally, they get made. A little bit of chemistry. And bilirubin is just one of those byproducts of heme. Heme is mostly iron, but when I break heme down, it turns into iron and bilirubin. And bilirubin is what causes jaundice and those sort of things. Is that making sense a little bit, maybe? Kind of? Kind of? Okay. If you look at the life lesson on page 281, this is more of just a, hey, this is a definition, if you want to know what it is. So we know that basically if I don't have enough red blood cells or hemoglobin, I'm anemic. The other end of the spectrum, which is much more rare, if I have too many red blood cells, that's called polycythemia. Polycythemia. And poly is one of those prefixes that just kind of means more or many, okay? So basically, polycythemia is basically saying too many blood cells, if you want to break it down that way. We won't get too medical terminology at this point, but the emia at the end means what? I mentioned this before, emia, blood. Emia is always blood something. Usually it means like blood condition or blood something. So basically this is saying too many cythemia, too many whatever in the blood is what it's saying. So basically if the rate of me creating new red blood cells is higher than the rate they're destroyed, it becomes an imbalance and I'm going to get too much. So polycythemia is a more rare thing that can happen with abnormal bone marrow development or abnormal bone marrow, like a bone marrow cancer or other blood cancers. Or sometimes this can actually happen in really, really extreme conditions of high altitude. Not like you're going skiing, but we're talking like you're climbing Mount Everest and stuff like that. There's a lot of ways to die climbing a mountain like that. Polycythemia would be a crappy way to go, but it is something like that. And then other stuff, things that are affecting your lungs are really going to be a culprit behind polycythemia. Because smoking or damaging your lungs, any kind of lung disease, that's basically your lungs are damaged so they're not efficient. So your body always chronically has this little bit of lower oxygen, which was low oxygen trigger in the kidneys. We just talked about it. EPO, and make more red blood cells. So if I have this chronic low oxygen, this cycle never stops. Remember the book just said it was negative feedback. So if I have low oxygen, my EPO gets kicked on, and my kidneys are telling my bone marrow, keep making red blood cells. But if I have a condition that's affecting my lungs, my oxygen's never really going to rise. So there's no negative feedback. The loop just keeps going. There's no negative of like the oxygen rose, and so now my kidneys will stop making EPO. They just kind of constantly dig. And I don't know the names and stuff like that, but I know with the whole EPO synthetic controversy with cyclists and stuff like that, I think there was a couple deaths associated with EPO, and a lot of it had to do with polycythemia. They're giving themselves a drug that makes more red blood cells. If their body couldn't compensate, they're basically making the blood very viscous. You remember viscosity from the first part of this chapter? So blood being viscous means it's like thicker. If I have too many red blood cells compared to what I'm supposed to have, that's viscous now. It's more thick. It's basically like dumping it full of sugar or something else. It's not good for it. Blood's going to be thicker, not going to flow well, i.e. blood clots, issues, stuff like that. Okay?
As a red blood cell ages.
So this is talking about red blood cell production, breakdown from 280.
Becoming fragile. As it passes through the narrow capillaries in the spleen, it begins to break down. Macrophages in the liver and spleen ingest and destroy old red blood cells. As they do, hemoglobin is broken down into its two components of globin and heme. Globin is further broken down into amino acids. The amino acids are used for energy or to create new proteins. Heme is broken down into iron and bilirubin. Iron is transported to the bone marrow, where it is used to create new hemoglobin. Bilirubin is excreted into the intestines as part of bile.
Yeah, that's just summarizing that. So that should be everything on 282A1. Again, polycythemia, just really know the word, right? Polycythemia, poly, too much blood, polycythemia. Again, heme is just summarizing all that. Heme is broken down. Excess bilirubin, if the body can't get rid of the bilirubin, which means there's a liver issue somewhere, that's what the yellow jaundice is. It's basically leaking into tissues, leaking into blood vessels where it shouldn't be, and it causes yellowing of the skin. So this is someone that with jaundice. You want to know it? It's yellowing of that, yellowing of the sclera of the eyes. It's very distinct. It looks made different than like pallor or pale, that sort of stuff. What type of anemia would someone be suffering from if they have issues with intrinsic factor in their stomach? I'm adding words because intrinsic factor is the thing. And vitamin B12 deficiency. What do they call this anemia? Pernicious anemia, yeah. Pernicious anemia.
What did you say when you asked the question? I'm adding something in. What did you say?
Intrinsic factor. So intrinsic factor is basically this enzyme that helps us absorb vitamin B12. And it's made in the stomach. So most of our vitamin B12 absorption is depending on intrinsic factor being made in the stomach. So if I have stomach issues like acid problems, stomach ulcers, maybe my intrinsic factor production is affected. Therefore, vitamin B12 absorption is affected. And vitamin B12 is just part of a chain of events that we need to help us make blood cells. And so without vitamin B12, I become anemic. And that's pernicious anemia. But it usually has a very layered why it's happening. It doesn't usually mean dietary vitamin B12 deficiency. It's usually something more than that. So white blood cells, 282. Well, I'm not going to spend too much time on this because the good news is that you've already covered most of these, which is good. The big thing for me is the three main guys that they call granulocytes on page 282, and there's a beautiful little chart there on page 282. The other name for white blood cells is leukocytes. So leuc is white, O is the conjoining vowel, and then cytes is cell. So leukocytes are white blood cells. And again, right, our white blood cells numbers are always going to be higher if there is an infection somewhere because, right, they're getting there. They're the ones that get there and do what they're supposed to do. Our phagocytes will be kind of the first on the scene, neutrophils, that sort of stuff. We learned all about these already, but again, they're made in bone marrow just like everything else. They hang out in lymphatic tissue and lymphatic organs like the nodes and the spleen and the thymus. And their goal is about lymphocytes, basically. The lymphocytes are just somewhere in that family. The main lymphocytes you've already talked about, T and B cells, cellular mediated immunity, humoral immunity, all that good stuff, okay? Basically, the key lymphocytes they talk about is the T and B cells, which are made for our long-term specific immunity, right? So the book breaks them down basically into granulocytes and agranulocytes. If that's the breakdown in the blood, how they break them down, we've broken them. When we talked about lymphatic and immunity, we just called them all lymphocytes, which they, for the most part, are. Most lymphocytes are T and B cells. Monocytes are known as the macrophages. So most of them fit into a granular sites, and this is just how they look under a microscope. That's all the difference really is, how they look under a microscope. Granulocytes look grainy on a microscope. That's why they get the name. Big deal, okay? But at least they're somewhat easy names. Neutrophils, eosinophils, is how you say the E one, eosinophils, and basophils. All the Phil cells, the Dr. Phil cells, okay? They're the granulocytes. And neutrophils you've already heard about. So I think that chart's a good breakdown if you want the big. The one you're going to see the most in any test is always going to be neutrophils, because neutrophils are the first word it tells us. And I tried to nail this home a little bit early in chapter 7, was neutrophils are the most abundant of all the white blood cells. There's 60 or 70% of all white blood cells we have floating through our body right now is the neutrophils. These guys, they're the first responders. So I'm going to show you another slide. But the neutrophils are your first responders. They are remember the chemotaxis is like a 911 call? So chemotaxis happens, the first guy on the scene is likely to be neutrophils, okay? Because they're the most we have. And does anyone remember how neutrophils destroy stuff? Pac-Man, they phagocytize. They swallow them up and destroy them. Neutrophils phagocytize. So they're going to take stuff, engulf it, and kill it. Again, they die in their battle, and so what equals pus usually is a bunch of dead neutrophils, bacteria, debris from the battle, okay? So neutrophils are your most abundant. They are your first responders, is how I always remember them, because they're the first guy there. First guy there, always. Mainly because they're the most numerous. So neutrophils are your first responders. So most ever you're going to be asked about neutrophils. You can never kind of forget they're the most abundant we have. They are the first responders, and how do they destroy stuff or clean up the mess that is infection? They engulf it, they swallow it, and digest it, break it down with enzymes. They phagocytize it, okay? Some of these other ones, I left some slides in here, but they're a little bit minor. I think they're more interesting. So eosinophils is the second one they list there. Eosinophils are interesting. They're a small part. Eosinophils are actually more reactive against allergic reactions. They kick in and release some histamine and do all that fun stuff that we hate. Well, we don't hate, but histamine can be bad if it's overproduced. And they kill parasites. So parasites you might have heard of, like tapeworm. I'm trying to think of the other ones right now, but ringworm. Some of these parasites that are more rare. So that's eosinophils. And I think I messed up and didn't do a slide for baeosinophils. Basophils are the last one on that chart. Again, much more minor. They're the ones that, remember, if you've been in if you've been in dosage at all, we talked about heparin recently. Basophils actually are the ones that secrete heparin. I don't have a slide for them. I kind of messed up there. But they're the last one on that chart on page 282. They actually secrete a little bit of heparin, which is trying to prevent clotting in an infected area, basically. They don't want the blood flow in an infected area necessarily to clot yet until they can, all the blood cells can get there and do their job. All these white cells can get there and do their job. So they're kind of preventing that in small micro doses in a certain area. And again, the other side is agranulocytes. The agranulocyte thing is not a huge deal. All it is talking about how they look under a microscope. I'm more concerned, hey, do you know the name of the 3 fill cells? Neutrophils are your first responders. They phagocytize. They're the most abundant, okay? Eosinophils are involved in allergy. Basophils secrete a little bit of heparin. Now I'm done. I just listed all of them. That's all you would need to know right there. Okay, summarize stuff, right? And then agranulocytes, you've already learned a bunch about. The T and B cells involved in specific long-term immunity. Monocytes are pretty much macrophages, and their job is their job is to hang out in specific tissues and eat stuff and kill it, okay? So you flip the page on 284. 284, there's a body at work section at the very top. I'm honing in on that because it talks about a couple words that I think are good to know for you guys. They're need to know for me, but they're going to be good to know. So leuko is white. So we have a couple names for having too little white blood cells and too many white blood cells, just like we talk about anemia or technically polycythemia, though again, polycythemia is more rare. But same thing. There's always a name for too much, too little, right? It's either going to be hypo or hyper. In this case, it's leukopenia, and leukocytosis. So leukopenia, certain viral diseases might cause us to have a low white blood count. So leukopenia, the one thing they give you is HIV and AIDS can cause leukopenia. Some cancers as well can cause leukopenia. This is a low white blood cell count. Does anyone have a guess if you remember anything about HIV or AIDS, why it might be causing a low white blood cell count? It attacks the T cells, specifically the helper T cells, which are part of our long-term immunity. So it is decimating basically the ability of us to make antibodies and to keep kind of producing memory cells. So HIV/AIDS is one of those that specifically actually attacks our white blood cells. So that makes sense why we'd have less of them, leukopenia. So leukopenia is too little white blood cells, which means that we're going to have trouble fighting an infection. That's going to be scary, right? That means that we don't have the ability to fight off an infection, something like this. And so people that have cancer sometimes can develop leukopenia, and depending on the cancer, that makes them more at risk. If anyone's been around a cancer patient before, a lot of times they're really on you about what? Probably wearing a mask, washing your hands, that sort of stuff. Why? Probably that patient has had a decimated immune system for whatever reason. Now, there's a lot of complication with cancer, which could be they could have a decimated immune system because of chemo. Always keep in mind, if you're a nurse or at all, that just keep in mind, chemo, by the way, is basically poison, just so you know. That's what it is. All chemotherapy is going to kill healthy cells. It's going to. That's why people feel like utter death when they're on chemo. And I can never knock someone that has cancer and they're like 80 and they're like, screw the chemo, we'll just ride it out. You know, peace, let's go be with Jesus. I can't blame them because chemo sucks. It's literally just taking poison. Hoping you're going to kill the bad stuff, but you're going to kill good stuff. So leukopenia can be from that. It can be from a number of things like in that family. But some viruses, especially that HIV that turns into AIDS, really can mess up our immune system. So leukocytosis is too many white bloods, way too high white blood cell count. And the easy explanation for this is written there, but what do you think it would be? Infection, 100% of the time. Most of the time, when if you have an elevated white blood cell count, every doctor under the sun, his first thought is going to be infection, and that's what they're going to investigate. Because what does that really mean? That means your immune system has kicked up a response, right? You've got a normal range. If I'm fighting an infection, especially a big infection, my white blood cells are going to kick up. I'm losing my voice. My white blood cells are, dang it. My white blood cells are going to kick up in response to that. I'm going to make more white blood cells to fight off something. So that's a normal white blood cell count there, 5,000 to 10,000. It's microliters. Don't stress it. Again, I told you guys don't stress numbers at all. For this one, right, that body of work up top is just giving you this. The names. What are the names of too little, too much, and maybe why would they? Again, pretty easy. Leukopenia, really scary HIV or AIDS, some cancers, leukocytosis, definitely probably related to infection. There, you're done, okay? Platelets and bleeding is talked about kind of like the next 3 pages. We're going to kind of summarize this a little bit. So platelets are also called thrombocytes. It's a fun word, thrombocytes. So their goal, basically, stopping bleeding. That's really the only goal of platelets. Platelets' goal is to stop bleeding. So again, when we get an injury, like a cut or whatever, and blood vessels get destroyed, we're going to bleed. But eventually, there's always a time when our platelets kick in and try to help us clump up and clot off the hole. You know, poke a hole in a vein, eventually it's going to try and clot off, okay? And by the way, too, don't stress it, but there is a life lesson about leukemia. Leukemia, you can kind of read into it. Leukemia is a weird, one of the cancers that can be a little bit weird, but leukemia actually usually can cause an extremely high white blood cell count. And that's a weird one. If you want to note that, I'm not stressing that as a need to know, but that is interesting. Kind of the reason why leukemia can do that is because you always think with cancers are trying to pretend to be you. Cancer cells are trying to pretend to be your cells. And sometimes cancer cells can retain function of the cells they're mimicking. So cancer cells if they're in bone marrow, they're acting like bone marrow. And what does bone marrow do? Produce blood cells. So if I've got leukemia, sometimes a bone marrow cancer is really going to, they call it a blood cancer because what does it do? It affects blood, and it's in our blood because bone marrow is so a part of this whole blood system. Without bone marrow, we don't make any blood cells. So it's so tied together. That's where leukemia comes from. But usually leukemia is going to jack up our white blood cell count because it's acting like bone marrow and with no regulation, just making cells left and right. So that's just a side note, interesting. Sorry, I just wanted to make not a big factor for me right now. I don't want to get too complicated, but if you're curious about leukemia and other blood cancers, there's a nice little discussion there. So really, if you're going to summarize platelets, just summarize them as their technical name. Like again, white blood cells, leukocytes; red blood cells, erythrocytes; platelets, thrombocytes. There's your technical names for all three main formed elements of blood, and their only goal really is to stop bleeding. Okay, there's your summary. The name for stopping bleeding is hemostasis. Hemostasis, like heme, I heard hemo, I know I'm talking about blood. Heme is blood, O is a conjoining vowel, and then stasis, what does that sound like? So static, stationary, I'm staying put. Like I'm trying to stay still, basically, stasis. If I'm in cryostasis, like a sci-fi movie, right, I'm still asleep in some kind of whatever. Stasis is like a stop, and not a stop necessarily, a stop, stay put, stable, there you go. Other words you can think of to kind of help you. Again, I'm just giving you words to kind of help you understand hemostasis. So there's a process for this, page 285 all the way to 287. Kind of goes into depths of this. Technically, platelets are this is more just, hey, the more you know. But platelets aren't really cells themselves. Platelets actually start off, did they show you on that book? They do show you on page 285. Platelets do start off as another cell called a megakaryocyte, which is just, who cares? All right, but the megakaryocyte is just a weird, random one. I'm not testing over megakaryocytes. If you know the technical name of platelets and what they do, you're in good shape for the most part. But they actually start off as this big cell, and the megakaryocyte just kind of breaks apart and then dumps its platelets. Do you remember a little bit about humoral immunity? Remember the B cells multiply into these cells called plasma cells, and those cells break apart. And when they break apart, they dump antibodies everywhere. So the antibodies aren't cells themselves, they're just a molecule, okay? Platelets are kind of the same thing. That's why they only live a few days. Platelets aren't really cells. They don't have a nucleus, anything like that. They are pieces of a cell called a megakaryocyte, and it just breaks apart and dumps its platelets into the bloodstream, okay? And so they're really small, and they don't live that long because they're not really a cell on their own, okay? And that's what they're kind of showing here. Megakaryocyte breaks apart pieces of itself and says, here's a platelet, and they just end up in the bloodstream. So how do we form a clot? So I've made this word known, but just as another definition, blood clotting, coagulation is what you call it. Coagulation is the name for the process of clotting blood, if you want to name it that way. The process of clotting blood is called coagulation, okay? And that's basically what they're talking about as you work your way down page 285 and page 286. They're talking about this process, okay? And basically they talk about there's a pathway to it. There's an extrinsic and intrinsic pathway. Now, you guys have learned enough about words in anatomy so far to know extrinsic probably means what? Outside something. Intrinsic probably means what? Okay. So basically there's factors, there's things that get initiated outside the blood vessel. So when a blood vessel gets damaged, the tissue around it's going to release some chemicals and start the process of blood clotting. And then inside the blood vessel that's damaged, there's going to be things that happen with clotting as well. So that's what they're talking about. All intrinsic, extrinsic is saying is that there's just two cascade events that happen in the blood vessel and outside it to make a clot happen, okay? And so how does a clot happen? It's talked about basically step by step on page 286. And it gets a little bit in the weeds, okay? So what they call all these, basically, all these steps, I'm going to summarize it a little bit better for you. Basically what happens is enzymes get released inside the blood vessel, there's your intrinsic. Enzymes get released outside the blood vessel, there's your extrinsic. Both pathways' goal is to help our blood vessel seal up and stop bleeding, to help us stop bleeding, to coagulate, okay? That's the goal. Basically, there's a bunch of enzymes that come together to do this. There's something called a prothrombin activator, which is, again, enzyme. An enzyme is like a hormone, like other chemical messenger we talked about. Usually enzymes just make reactions happen. They're usually chemicals that are going to make a reaction happen. That's what an enzyme is. So if you're defining an enzyme, you can think of it very similar to a hormone or very similar to a neurotransmitter. It is just a chemical messenger. It's a chemical that's going to make an action happen, okay? And that's released by both in and outside our blood vessel. Prothrombin activator to prothrombin to thrombin to fibrin is so great. Isn't these names great? So how would you summarize it? I would leave it pretty simple, okay? The end goal is this material called fibrin, which basically forms a web, okay? Fibrin is a very strong, sticky thread or a web, okay? Fibrin is a sticky web that's goal is to block off the blood vessel, and while it does that, it catches platelets, these little odd-shaped pieces. The platelets get kind of activated by all this. The platelets respond to these enzymes, and they get sticky, and they connect to the sticky fibrin at the injury site, and they form what's called a platelet plug. And they plug off this thing. And that's what the image is showing you on page 286. It's saying, okay, fibrin comes together, all the platelets get stuck to it. You know how a bug gets stuck in a spider web, right? Sometimes that bug was just flying around. That bug was just doing its own thing. Whatever, it got stuck in the web, and now it's there. It's the same kind of concept. Fibrin is a sticky web we form around our blood clot, and the goal of that web is to catch passing platelets because all these enzymes have made them sticky in the area, and they all stick together and gum up, okay? And it plugs the hole, basically. Whatever the hole is, it plugs it. And this is why pressure can help with this too, because pressure, you're compressing the blood vessel, and you're kind of forcing this to happen on its own. So there's a lot of processes, but I would just say enzyme, enzyme cascade equals sticky web called fibrin. Fibrin catches platelets, not feelings, okay? Oh, I thought it's funnier in my head. All right, platelets, platelet plug. Everything the book is talking about on those 2 pages, you could summarize that way. That's what they're basically trying to get you to, okay? The extrinsic, intrinsic thing is just saying, hey, this enzyme cascade happens inside the blood vessel, and it happens in the tissues outside the blood vessel. And all the goal is to try and get this platelet plug to happen and plug up the hole, okay? And a lot of these enzymes they refer to, they usually like to call them also known as. That's what AKA stands for. Also known as in case you see this somewhere. Factors. These enzymes that do all this are known as clotting factors. Does that make sense at all? Are we with me at all on that one? Maybe? It's very silent. I don't know. I'm very alarmed. It's very quiet now. It's very Monday. But the very Monday says, let's shorten it. So blood clotting, hemostasis is two pathways of enzymes happen. Those enzymes are called clotting factors. Clotting factors make a series of events happen that we want to produce fibrin, sticky web. Sticky web catches platelets, form a platelet plug, and hopefully block off the hole that's now in my blood vessel, thus clotting, aka coagulation. You got to shorten it because otherwise it's really a nightmare. It really is a nightmare anyway. So two things to add to this that not really make it much different, but two things that are super stressfully important, okay? Super duper important. There's a fast fact on page 286, and then on page 287, there's the body at work, and I'm going to highlight both these things. The fast fact tells you that there's something really important that you need in here. Calcium. Calcium makes another display of its power. Calcium we need to help us with muscle contractions. We need it with nervous system impulses. We need it for life because we need calcium to help activate some of these clotting factors. So calcium plays a huge role in this. Without adequate blood levels of calcium, clotting process is going to be doomed, okay? So we need calcium. The other thing that the person that makes most of these makes most all of our clotting factors, the liver. So, if I have liver problems, do you see now there's a bunch of chain of events that can happen if I have liver problems, but one big chain is that I might be more at risk for bleeding just because I have a liver that doesn't function right. So far what you know now with the liver, it has like 250 jobs, but so far you know if I got liver problems, maybe I'm going to have trouble regulating my glucose because of its role in that. If I have liver problems, we talked about bile, but we'll talk about that more with digestion. If I have problems with my liver, I might have problems clotting because the liver is the guy that makes all these clotting factors. If I don't have enough of them, the reaction's not strong enough. I don't get fibrin. Fibrin doesn't catch platelets. No platelet plug. No clot. No coagulation. So that's the body of work, and it mentions one specifically. Vitamin K. So I talked about this, I mentioned this a little bit briefly actually in dosage, but a common medication we use to treat clots, we use as an anticoagulant, is called warfarin or Coumadin. Who's heard of Coumadin or warfarin? Maybe some people? What warfarin does is mess with the synthesis, the creation of vitamin K, a huge clotting factor. And so that's how warfarin does anticoagulation. It makes our blood thinner, quote unquote. It's stopping us from clotting by messing with the production of vitamin K. And the antidote for warfarin overdose? Vitamin K. you give them vitamin K. That's the antidote. So that's a rabbit trail, okay? That was a rabbit trail about warfarin, just to give you an example of how, but vitamin K is like the biggest clotting factor in your mind. That's the most common thing you're going to see in healthcare. As far as clotting, coagulation is vitamin K. There's a bunch of clotting factors, but that's a big one. And that's what that body of work is talking about down there. It also does talk about that vitamin K is fat soluble and it's absorbed in bile and digested and you need to poop it out and blah, blah, blah. either way, the easy thing to think of is liver makes clotting factors. What's a big clotting factor? Vitamin K. If I have liver problems, I have clotting problems. Done. Okay? How do I need to clot? Clotting is called coagulating or coagulation. I need clotting factors. I need calcium. And I need to form some fibrin. And platelets need to catch on the fibrin web and make a platelet plug and stop all this up. Okay? Page 287 just talks about how a clot dissolves. I'm not too focused on that. It's basically kind of the opposite. We have enzymes dedicated to dissolving a clot once the blood vessel heals, that sort of stuff. Shut up.
I have a question.
Yes.
So what is it called when somebody has a blood clot and it's moving because they have too many blood clots?
And it's moving.
Yeah.
Any blood clot can happen. So
Like I know it's good for your body to be able to move.
it just means like if my blood is thicker for some reason, if my blood is, if I'm diabetic, then my blood's going to be thicker, so more sluggish flow, more likely to have blood clots. If I just have peripheral vascular or peripheral arterial disease, then I have atherosclerosis, which is damaged blood vessels that's going to cause clots. If those clots will start somewhere, but if they break loose, that platelet plug, instead of staying where it was, might just be now becomes what they call an embolus. It is a moving clot, and then it will end up somewhere really small, and that's going to cause, probably full blockage of that artery, damaged tissue. So that could be a heart attack, but a lot of times it ends up in the lungs or in the brain, and that will cause a stroke or what they call a PE, pulmonary embolism. So, all right, let me make one other point. That's nice to know. That life lesson at the top of page 288 talks about blood clotting disorders. The only thing I'm making a note of is that they talk about the two names of blood clots. So, a blood clot that's like stuck in one place inside the vessel is called a thrombus, which kind of goes in ties with platelets are called thrombocytes. And then if a piece of that clot or the whole clot breaks off and circulates through a bloodstream, they call that an embolus. So a thrombus is a blood clot kind of anywhere, which again, a thrombus by itself may not necessarily be bad. It may be clotting an injured blood vessel. But an embolus can be bad because an embolus means that clot has moved and went somewhere else, and you don't really want that. That could end up in the lungs, end up in the brain. It's not good. So those are just distinctions. Those are not nice to know words. Okay, so blood types. Blood types, they break it up into basically 4 groups they call ABO group. So all of you in this room fit somewhere in one of these 4, these ABO groups, okay? One of the 4 types. If you're any other type, then you're an alien. You should come see me. I'm curious. All right, so that's it. That's all you got. So the easiest way I tell people with blood types is that go back and just think about what antigen is. Antigen is a protein marker that says something about yourself, okay? So all blood types are based on what the antigen is on the outside of their type, okay? And there's basically, for dad joke aside, a blood feud, between different types of blood. There's certain blood types that just don't like each other, and the main culprits is A and B. A hates B, and B hates A, okay? And so that's kind of the thing to mean. So when I say antigen, what I'm saying is that you have a blood cell, and it has a marker on the outside. If this says A, you are blood type A. That's how they determine your blood type. If this says B, then you're blood type B, and these 2 blood types don't like each other. But to see this more in depth. But that's how we establish blood types. So the way that you identify what blood type you are or what ABO group you belong to, one of the 4, is the antigen on the outside of the blood cell. Tells me what I am, okay? So let's look at all of them together. I think an image makes it a little bit easier. So here's your blood types. Blood type A, B, O, and AB. That's it. There is nothing else. There's no other type of blood you can be, okay? Now, the positive, negative thing you might have heard before, we'll get there. Don't ignore that for now. We'll start here. So, what they're basically saying is that if I'm blood type A, okay, I've got an antigen that says A on there. And A hates B, so when we are blood type A, we automatically, from the time we're born, make antibodies that are against B. So everyone that's blood type A, right now in your plasma, you have antibodies floating around that are anti-B. They are against B. There's a blood feud. A hates B and B hates A. So if I'm blood type B, my red blood cell has antigen on it, okay, that say B. And because I'm blood type B, I have made antibodies against A because I hate A. You understand what I'm saying so far? Okay. You wouldn't make antibodies to fight your own blood cell because then that would be a problem. You don't want that. So, where it gets weird is A, B, and type O. So the goal of antibodies is kind of in their name, right? Anti is what? To be against something. So an antibody is always against a specific antigen. So when I'm blood type AB, what they're saying is that you have a blood cell that has an antigen for both A and B. So guess what antibodies you have? None, because why would you make an antibody anti against your own antigens? You see what I'm saying?
Second question.
Yes.
So, but what if you get some blood and it, A blood and it, affects the B cells that you have?
You're gonna go into a reaction called agglutination. You're gonna have a hemolytic anemia and die if you're not treated.
For real?
Yeah.
What did you ask? Because you have AB, so you can eat the blood. But what
Wait.
if you get A blood?
Wait. You said wait. Well, I thought you said if you're B. Sorry, I misunderstood the question.
No, AB.
We're gonna talk about that. Hold on. Just let me establish this first. Sorry, I thought you said if you're B, you get A. What happens? You die. That's what happens. If you're,
I'm talking
yeah,
about AB.
yeah. Hold on. So we'll get there. We'll get there. Hold on. Let me do my thing. All right. So do my thing. All right. So if I'm blood type O, this means I have no. Like think of O as like 0. O is saying I have 0 antigens on the surface. That's what O is saying. So I've got no antigen. I'm baby smooth, no antigens marking my blood. So now they categorize me as O, which O decides that, again, there's a blood feud, so it has antibodies against both types of blood, against A and against B, okay? In this plasma floating around, okay? So, on to your question. They categorically talk about, so A and B is pretty straightforward, right? Blood type A can't get B, that's for sure, because antibodies are gonna attack it. Blood type B for sure is not gonna be able to get A, because if I give you A cells, they're gonna get attacked by the A antibodies. The reason that transfusion of blood works is a little bit of the principle at the very beginning of this chapter. Remember I talked about that if I take some blood out, I can put it in a centrifuge and I can spin it down and separate the plasma from all the formed elements, from the red blood cells and some of the other stuff. Do you remember this, the test tube at the very beginning? So what we do typically when we give blood, we don't give whole blood. We take whole blood from you and they go and spin it down and they give what's called packed red blood cells, PRBCs, packed red blood cells. This is what we give to people, which means what we're eliminating is the antibodies. We are eliminating the plasma and we are just giving you the cell. So think about transfusion reactions as back to the antigen. What type of antigens on the cell? Don't think about the antibodies when you talk about blood transfusion reactions because that's not what we're giving somebody. 90% of the time, we are giving someone packed red blood cells. We have gotten rid of plasma and dumbed it down just to the cell. So the only reaction that's going to happen is whatever antigen's on the surface. So this is why they tell us that the blood type O is a universal donor, which makes sense because what am I giving? I'm giving a naked blood cell with no antibodies. I'm giving you this. So stop it. So if you look at it, right, if I give you this blood cell, okay, to AB, is AB going to do anything against it? No. Look at it. Give a smooth type O to B. No. No reaction because there's no antigen. To type A, B antibodies don't care. Nothing to react to. You understand what I'm saying? So this is why you are called all the time, if you're type O, to donate blood by the Red Cross. Because you are the universal donor. In every emergency room in the country and around the world, the blood type that is stocked and ready for emergency situations is type O. It is universal donor. Any other blood type of the 4 can receive O because their antibodies are not going to react to nothing because antibodies only react to a specific antigen. And there is no antigen on type O. So it doesn't care. Okay? AB is known as universal recipient or receiver, whatever. Universal recipient, and I can't spell recipient because I'm dumb. So anyway, it doesn't matter. You receive, AB is a universal recipient. What does that mean? AB can receive blood from anybody. So we just saw it can receive blood from type O. Again, if I take type B and go over here, it doesn't have antibodies against it. The reason blood type AB can receive anything is it has no antibodies that are going to fight. Because it has no antibodies at all. Because it can't, it would kill itself. Now type AB, is there anybody that knows they're type AB here? Really? All right, you're in 4% of the population then. You're unique. Yeah, yes.
So I'm O. I can give out, but I can't receive what from an O.
You can only receive from an O. So let me go on that rabbit trail. All right, reel back in. All right. So her question was too, I'm type O, so I mean I can give blood to anybody. The answer is yes. But you can only receive. Let's think about it. Who could O receive from? Let's look at it, right? Remember, type O has no antigens on its surface, but because it has no antigens, it's made antibodies to fight both A and B. So if we look at A, can type O get, come here. No. Yeah. It can't take A, right? Because look, bam, antibodies attack A, bad deal. Can it get type B? No, antibodies attack B, latch to it, bad deal. What about AB? No. Nope, still no. Because look, antibodies for both, double bad. They can only receive blood from type O. Write that down. Write that down. That's the best ever. Write that down. Write that down. That's good stuff. Write that down. So the things to remember is, starting from the big strokes, is that blood types are what they call ABO groups, 4 groups of types. And AB hate each other. And so our blood types are A, B, and O. O is a universal recipient, O is a universal donor, It can give blood to anybody because it's not going to cause a reaction. Because again, you have to remember this key element here. You cannot think about transferring whole blood to whole blood. And that's a whole different thing. Whole blood to whole blood is going to have to be everyone's exact blood type to their exact blood type for the most part. No, huh?
Whole blood to whole blood. So if you're type B, you can receive from type B.
So if you're type B, let's think about it. What can you receive? So if I'm type B, I can't receive A because A is going to cause a reaction. Can I receive AB? No. But can I receive B? Because I have A antibodies, they're not going to fight B. So if you're B, I can receive from my blood type and O. If I'm A, I receive from my blood type, same thing, or O. That's why they call AB the universal recipient, because AB cannot donate. Really, nobody can use AB blood except AB. That's it. That's all they can only use it. But they can receive all the blood types. That's why they're a universal receiver, because they don't have the antibodies, so they're not going to react to anything. Yes. Who? Oh, I don't even have that much info on that, so I can't speak into it. I've only heard of it.
So if you're AB and you want to be an organ donor, how does that work?
Well, organ donation is a whole nother rabbit trail a little bit, because not only, well, one, the blood type has to match. So if you're AB and an organ donor, your organs would only be able to go to someone that was AB. But past that, there's like 6 other factors that, like, again, genetic factors, clotting factors, like a lot of stuff has to line up. So, like, if you're, for organ donation, like DNA, like even if you're a family member, it may not, like it could be a son, father, they're more likely to match, but it's not a guarantee because there's so many factors that have to come into play. And that's why organ donation is rare, really. It's has to be like a perfect storm. It's like 7 criteria. If you have to meet at least 5 criteria to even for any doctor to even think about doing an organ transplant. If it's like 4 or less of this criteria they have lined up, then they're not going to do it because the likelihood of tissue rejection is too high. So it may not be exactly 7, but that's how they look at it like that. It's a scale, and that's why we have a giant transplant committee that's universally global. Okay, so again, if you can always figure this out, right? If you go back to just know that every blood type has the opposite antibody. And type AB, because it has both, wouldn't have any antibodies. And type O, because it has none, has both antibodies. So everyone has the opposite antibodies. And when I'm giving it, I'm giving packed red blood cells. So go back to thinking about the blood type and the antigen on it, okay? So if I just pose a question like that, let's say I am blood type A, which I am. I am A positive. We'll talk about positive and negative. I'm A positive. What blood types can I receive if I'm A? Let's think about it. O for sure, because it's universal donor. And A, that's it, isn't it? Because if I get AB, my B antibodies will attack it. If I get B, definitely B antibodies will attack it. So I can only, basically, your blood type is, yes. No, O has no antigen on it. An antigen is a protein marker that says your cell is what? So O gets labeled O because it has no A or B antigens at all on its surface. And it makes antibodies. Antibodies are against something for both A and B. It's defending itself against both A and B.
So he has no antigens but make antibodies?
Yes.
So A and B has both antigens?
No. There is no O antigens. There's only A or B. Well, that's why they call it ABO group, but there's really the only antigens that are in play here is A or B. Yes. No antibodies, right? If I make an antibody, that would attack myself. Yeah. So the only antigens in play in blood type is A or B, and that's how we determine blood type. And again, AB is a rarity, 4% or so is what the book says. O is pretty common. I think that's somewhere in the neighborhood of 40%, and then another 45% is A, and then B is pretty rare actually too, like 10 to 12%, something like that. Anybody type B in here? Okay, you're rare, 10%. Someone said, I did blood testing. There's a blood test kit you can do, and I did that for a lab in A&P in college, but we don't really have a lab component, so I'd have to jump through some hoops for us to be able to do that. So anyway, but it doesn't really matter what your blood type is, but if you go to war, you should probably figure it out. That's what every war anyone's ever been on, they usually write their blood type on bags or the boots and stuff like that. Because in war, guess what? If someone's bleeding to death and you need to give them blood, it helps to know what blood type they are, doesn't it? Because you're doing a whole blood transfusion in the field. I've seen this. So it's a big deal.
What about in the ER when you get a trauma and they're like, okay, just hang no blood?
Yes. Because it's not going to cause a reaction for the most part. That's where we got to get into positive and negative. Because truthfully, the most sought out blood type in the world is A negative. Or A negative, excuse me. O negative is what I meant to say. O negative. So there's way less reactions. O negative is what they're going to want. O negative blood is very hard. It's not hard to find. It's just it is the golden blood in the sense of it's going to cause the least amount of reactions. I can give it to Jane Doe, John Smith, comes in, no license, no identification. I can give it to anybody, and it's not going to cause a reaction. It's going to, if I need blood, it's going to save their life. We can figure out blood type after that. It'll matter, but it won't cause a reaction. So this is where you got to establish, though. This is talked about starting on page 288 to 289. So what happens if I get the wrong blood type? What happens is, say I give A to B. If I give an A blood type, why you hate me so much? If I give A to B, it's got the antibodies against A because they have a blood feud. A and B hate each other. The antibodies will latch on to this antigen and latch on to all of them and to cause the red blood cells to clump up. A reaction like this is called agglutination, okay? This is the reaction that happens when the wrong antibody attaches, or not the wrong antibody, but if someone gets the wrong blood type, this is the reaction that's happening. It's called agglutination. It's where the antibody basically glues blood cells together. That's how I remember agglutination is like the blood cells get glued together and they clump up. And that's going to cause blood cell destruction. That's going to cause blood clots. This is a hemolytic anemia at its finest, okay? So most of the transfusion reactions I've ever dealt with are more allergic reactions, more histamine and more milder. I've never firsthand seen a full-on agglutination hemolytic reaction from blood. If that was to happen, people's blood pressure would drop, they would become paler, and their heart's going to stop unless you figure out the problem. Just as a nice to know, if you were a nurse and you were giving someone blood and they started having any symptoms of reaction, I'm not going to teach you any symptom reactions right now, but if they started having symptoms, some of the stuff is like severe back flank pain, headache, fever, chills. If they start having stuff like this, what do you think the first thing you should do as a nurse?
Stop the blood.
Yay, you passed the test. I bet you $1 million, and I don't have it, but that's how confident I am. I do not have that, I promise. But I would bet my life savings that some of the first questions you're going to see in first trimester, that's going to be one of them. It's going to be a nursing question that says, your patient's having a reaction to blood. What's the first thing you do? Stop the blood. That's your easy first fix, you know what I mean? Stop giving them the thing that's killing them, and then, other things. Then do other stuff. But that's the first thing. So anyway, that's a rabbit trail, but nice to know. So again, blood types, go back to what the antigen is, and it's going to have the opposite or no antibodies. So again, A has the opposite, B antibodies. B has against A. It doesn't like A, so it's against A. AB has both. It loves everybody. AB is a universal recipient. Everyone come here and give me a hug. That's AB, okay? It's a universal recipient. It can receive any blood type. Type O, very particular, what's the philanthropist, okay? It likes to, go and give to other people, but it's a little stingy with its money because it's only going to take deals where it gets its own blood type. I don't know. There's your... So, what's my next? So again, blood type, ABO, only 4 of them. Universal recipient, AB, really rare. Universal donor, pretty common. AB has no antibodies. Again, blood type O the names talk about what the antigen on the cell is. What is it marked as? Type O has no antigen, so it's a 0 antigen, says O. And yeah, and you are somebody's type, okay? Yeah, it is cheesy. So the blood type reaction is agglutination. This is clumping red blood cells. They clump together, they burst, they fall apart, so oxygen transfer is going to be affected. Hemoglobin blocks stuff in the kidneys from being filtered out. It's a whole bad deal, okay? So if someone gets a full-on hemolytic anemia from agglutination, I mean, we're talking kidney failure, liver failure, like multi-organ system failure, basically, or MOSD. This is a slide that you don't have to know, but I included in my PowerPoint because it's a nice, transfusion reactions. And so for you guys as LPNs, most of the time, all the time, the way the laws are and the regulations for LPNs versus RNs, you guys cannot start blood, but you can maintain it, okay? I have had reactions happen halfway through a unit of blood. Again, they're usually more minor, but they can always be scary because you're just not sure. You can't always tell what's going on. They're usually more allergic, and that would be different stuff people have in their blood, okay? Again, depending on what people are exposed to, that's why if you've ever donated blood, it's about 1,000 questions, you know what I'm saying, right? And it's like, oh, if you lived in Germany during the mad cow disease outbreak, you're done. You know what I mean? Like that kind of stuff. Like my buddy was born in Germany on a military base in like the late 80s, and he can't give blood because there was a mad cow disease breakout in that time period. Like that's how detailed it is, because if there's one speck of something off, it could cause someone else to have a reaction. So, but yeah, typically you guys still can maintain blood. So even after the first 15 minutes, most reactions will happen in the first 15 minutes, and that's why an RN stays in there and should be doing vital signs every 5 minutes for the first 15, and then usually it's every hour after that. But I've had reactions happen halfway through a unit of blood, so it can happen. But this just kind of gives you an idea of like what someone would show. So this is a nice to have. I just included this so you have it for the future. But again, typically if someone is hemolytic, it's chills, fever, heart rate jumps up, low blood pressure, they're breathing fast. That's all bad. Like blood cells are getting destroyed. Allergic is much more feeling anxious and maybe even lung wheezing, but a lot of rash, hives, itchy. A febrile reaction could be for a number of reasons, but they're going to be similar: headache, heart rate up, maybe chills, that sort of stuff. It just depends. This is just a nice slide to have. Let's simplify it. So everybody in here is going to be classified. Everyone gets classified as you're either whatever blood type, positive or negative, okay? What the positive negative is talking about is what they refer to as RH group. So it's positive or negative. So RH positive blood. So I'm A positive. This is what my red blood cell looks like, okay? It's a red blood cell with an antigen that says A, right?
Right.
Okay? It also has an antigen that says this, RH. That's why I'm RH positive. If you're A negative, your blood cell looks like that. That's the only difference. RH is an antigen that's on red blood cells that says, I have it. You either have it, you're positive, or you don't have it, you're negative. That's what it means, okay? It is something you are born with. It is not something that can change. It is not something that can develop. It is how your red blood cells are made in the womb. So it depends on your parents. So it is impossible for both your parents to be negative and for you to be positive. I'm sorry, it is impossible. Neither one of your parents had it. I got sad news. One of them may not be your parent. That's happened before. That's happened before, okay? If you know your parents' blood type and you sit here and start thinking, you go, wait, what the? Yeah. That's how genetics work. I've read Reddit stories about that. It does happen in college. Like, oh, I'm blood type A, and both my parents are, one of my parents is, both my parents are O. Oh. You should really have a long talk with your mom. All right, so moving on. Just saying. I'm just saying. So don't kill me. I'm just the messenger of truth, all right? So to be positive or negative, that's going to come from mom and dad, okay? It's just another antigen that marks the red blood cell, okay? So blood does not normally contain anti-RH antibodies. So for most of you that are negative, there should be no reason that you would have antibodies against RH, because what negative means, it means that your blood has never seen this. Your blood does not exist with RH. They sometimes call it RH factor, but it's just your blood, if you're negative, means your blood cell does not have an RH antigen on it, and there's no reason your blood would have ever seen RH before. So if your body's never seen something before, it's not going to make antibodies against it, okay? Because it's like a foreign antigen. I'm not going to have immunity against flu A if I've never seen flu A. You know what I'm saying? I'm not going to have it. So it's not normal for anybody it's not normal, okay, for RH negative blood to have anti-RH antibodies. That's only going to happen if you were exposed to Rh positive blood, either through a transfusion or pregnancy. That's the only way it's going to happen. That's the only possible way. It's got to be a transfusion or pregnancy. That's it. That's the only way someone can have anti-Rh antibodies. That's it. Those two things. Because it's an antigen on a red blood cell. So your body would have had to be exposed to red blood cells that were carrying an Rh positive antigen, saying Rh on it. An antigen that says Rh, okay? So again, if you're Rh negative in this room, if you're A negative, B negative, O negative, whatever, it's just saying that your blood cell has just the ABO group antigen and no Rh antigen on it. I'm A positive, so my blood says A and Rh. We tracking with me there so far? Okay, so let's look at what happens. Let's look at a picture. See how would I end up with anti-Rh antibodies? Let's see how that would happen. Okay. And this is why O negative is the king of the castle when it comes to blood, because when they keep that blood, it's when someone comes in that has no name, no ID, no nothing, right? They're a person bleeding to death on the table. We need to give them blood. Well, we can throw O positive at them. But we'd rather not do that. If we have a choice, O negative is the clear choice because there's no other antigen, which means their body's not going to react to it. You know what I'm saying? And because it's a universal donor, it's not going to cause any reaction. So all hunky-dory, okay? So this is the picture they're talking about on page 290. But if someone with Rh negative blood, so again, say you're A negative, you have a red blood cell that says A. I'm just using A as whatever. Okay? No Rh factor. Okay? You received a blood transfusion. Okay? And you got some A positive blood. This is why they do cross-matching. We don't just give blood willy-nilly in the hospital for this reason, right? You get some blood you're getting blood cells that have A, which is fine, but they also have an antigen that says Rh. Or think about how immunity works. Think about your long-term immunity, right? Takes time to happen. You're exposed to Rh now. Your body goes, what is that? Because, right, it's foreign. Your body doesn't know what this is. You're negative. It doesn't know what it is. So anything foreign, my body is going to eventually make a memory cell and make antibodies against it. So that reaction, someone could have a transfusion of Rh positive blood on accident or whatever the circumstances is and not have a reaction at all to it. But at that time, the reaction caused my immune system to eventually, right, humoral immunity, T-cell immunity, I'm going to make antibodies now that are anti-Rh floating around my plasma, which is irrelevant to me in my daily life. But if I was in wartime or I was a soldier and I got a whole blood transfusion in the field and it was Rh positive, I come back home, I get a stomach ulcer, I get bleeding, they got to give me blood. If they were to give me Rh positive blood again, what do you think is going to happen now? Yep, agglutination. That Rh, that anti-Rh antibody is now going to attack the red blood cell I get, okay? This is why we check this all the time. How does this work in pregnancy, okay? A little bit more confusing, but the same principle. So again, if you're Rh negative, your body doesn't know what Rh is. That's what it means. It doesn't have that antigen. If I was Rh positive and someone gave me Rh positive blood or Rh negative blood, I don't give two craps as long as it's the same blood type. Because I have Rh. Why would I ever make anti-Rh antibodies? You see what I'm saying? I have it. So someone that's positive can get positive or negative blood. It makes no difference to them. Their body already knows what Rh is. Their immune system is not going to react by making antibodies to something they already know what it is. You see what I'm saying? It's a foreign thing. If I'm negative, if my body comes in contact with positive blood, it's like seeing a foreign substance. So the immune system kicks its process off and makes antibodies against it. So again, that process takes time. So it's usually subsequent interactions, as secondary interactions. So this is what they're saying, right? I'm negative, all hunky-dory. Someone gives me positive blood. My body says, what the hell is that? It's RH. I don't know what this RH thing is. It's foreign. Destroy it. Makes antibodies to fight RH. It's all hunky-dory until I get RH positive blood again for some reason, then agglutination. I attack. So how does this work in pregnancy? Similar concept, okay? So again, similar condition. So because maternal and fetal blood does not mix, so this is something that's hard to know from OB stuff, but typically what crosses the placenta is not mom's blood. What crosses the placenta is mom's oxygen and her nutrients from her food. And some antibodies can cross the placenta, but whole red blood cells, stuff like that, they don't.
So is that why sometimes like babies die within the mother's stomach?
Well, there's not good statistics on this, but this condition that we're talking about, erythroblastosis fetalis, yep, that's the condition. Erythroblastosis fetalis is considered, especially in rather undocumented parts of the world, to likely be the cause of a lot of miscarriages. But in America, we have things that can treat it. If this happens, hold on, just stay with me. I jumped ahead a little bit there. So let me jump to the picture. I think the picture is better. Let's do the picture. We know what RH is now. Okay, so everything's fine. Two people, they love each other very much, right? They do the intercourse thing, okay? Coitus, all right? Make a baby, all right. They get married and make a baby. All right, at me later on that one. But anyway, all right, they get married and make a baby. All right, all happy. Well, mom is RH negative, which again, what does RH negative mean? She doesn't have RH antigen on her cell. She's never seen it. Her body doesn't know what it is. So she's living her best life. Doesn't really matter. So I'll just use A, or we can use O. It doesn't really matter. It doesn't matter what blood type you're talking about. So we can say she's O negative. Let's say dad was O positive, right? So,
this is Ashley's life story. Literally.
yeah. So, yeah.
That's my blood type.
Yeah.
That's my husband.
So let's say that dad of the baby is O positive, and baby gets such genes. Baby's red blood cells develop with RH antigen. So what this is saying is baby's blood is this, no other antigen on it except RH. While the baby's in the womb, hunky-dory, because there's a placenta here, and the only thing crossing this barrier is some antibodies, oxygen, nutrients, small stuff, small chemicals. But whole blood cells, other stuff like that, they don't cross. Okay? So that's fine. It's all hunky-dory. But mom, wait, did I skip a step? Oh, delivery. Delivery, a lot of times blood's going to mix, okay? Not every time, but there's a high likelihood that blood is going to mix, and mom's blood is going to likely, because the placenta gets detached, there's a whole thing happening, right? Mom's blood mixes with baby, okay? And then guess what? Again, the baby's positive. Like I said, someone's RH positive. It doesn't matter what blood type you throw in them. They don't give a crap because they already have RH. So as long as it's the same blood type, they can get O or they can get A, whatever, right? They don't care. The RH doesn't matter to them. They're positive. But it is going to matter to mom who's negative. So mom is negative. When she gets exposed to this RH, her body does what? It makes antibodies first. It's going to make antibodies to attack it first. And because the delivery happened, and they usually don't, I know deliveries last 15 hours, but typically that instance where the blood mixes, the baby's already out and gone, right? Okay, so now mom is living and floating around with anti-RH antibodies. Fine. She keeps the same husband. They make a second baby. Yay, baby number 2. Hopefully it's not twins, okay? I love my twins, but holy hell, okay? It's a lot. It's a lot. 4 kids is a lot. 4 kids is a lot. All right, so anyway, they get number 2 baby. Same husband, so she is still O negative. Her blood type did not change. You hear me? It doesn't change. If you are O negative, that is telling us what is on your red blood cell. O negative means there's no RH on your blood cell. If you're O positive, it means there's RH on your blood cell. You were born that way, it doesn't change. So again, first baby, all fine, okay? But now, during the second baby, because of that blood mix, she has Rh antibodies against Rh. So, guess what can cross the placenta? The antibodies are small enough to make it across the placenta. And if they mix with baby blood, that is baby in trouble. That is agglutination in the womb. And this condition is known as erythroblastosis fetalis. Yes. This happens all the time. This is very common. This is why they do blood typing and screening when you get pregnant, or you should. And this is why people that don't go see doctors when they're pregnant have an abortion, and a lot of people it's unstatistically able to prove, but the likelihood of that is the reason they had an abortion. And I say not abortion, when they had a, like, miscarriage is the proper term, but either way, it's still the same thing. A baby died. So, again, at me later. Still the same thing, okay? Same thing. It is the same thing, 100%. 100%. Same thing. Your baby aborted. That's what the medical term for a baby's death in the womb is abortion. That's all it is. It's not it's a word that the people in the media like to throw around, but that's all it is. So
if they do a test and the mom is Rh negative,
right. So hold on, let's get back to so Rh. So yeah, finish your question. Go ahead.
they do a blood test
Right.
and the mom is Rh negative with the antibodies and the baby is Rh positive, do they go ahead and terminate pregnancy?
No. So we have medication that can basically downplay those antibodies and let the baby out. And then it's like, okay, we'll have to, next time you get pregnant, we'll have to check. You know, if the baby is positive again, you'll have to do the medication. We'll watch them. Again, what they usually attribute this is to, you know, spontaneous abortion, whatever you want to call it, miscarriage. What they usually attribute this could be a possibility for people that haven't had any medical coverage at all. If you're 6-7 months pregnant, especially in other countries where the healthcare access is much less than we have in America, that could be attributing to it. It's hard to say.
What's the word called?
The condition, erythroblastosis fetalis is the condition. So erythroblastosis fetalis is a condition where the baby suffers from agglutination, a hemolytic reaction to mom's antibodies. Need to know. I wouldn't spend this much time on it if it wasn't something need to know. Blastosis fetalis. Condition, let me see. Well, I mean, the book talk. Let me think about it. It's a condition where the baby is suffering hemolytic anemia from mom's antibodies crossing the placenta. Her antibodies against Rh because the baby's Rh positive. And so this would lead to, like, again, if it wasn't caught, this could lead to, miscarriage. This could lead to premature birth and premature, like, bleeding disorder. I mean, it could lead to a lot of stuff. But typically, again, we have medication that can suppress the antibody reaction. And people, my wife, all of her kids, the same thing. My wife is O negative. I'm A positive. Guess what blood type all my kids are? A positive. So again, usually it's just a screening and a watch, really. This does not happen every time, okay? It's usually a screening and a watch. There is medication involved, but it is something we screen for and watch for because it is a possibility. So I'm not saying erythroblastosis fetalis is happening like every day. Well, it is happening every day, but I'm not saying it's happening to every woman. I'm just saying that it is a possibility. It's a rare case, but it is a possibility. It is always going to be a possibility if you are someone that's negative and your baby is positive. It's always going to be a possibility.
Did your wife have to go through that?
Yes. Yeah.
So
But
it's like really common.
it's very common, yeah. It's very common. I'm just saying it's very common. I'm just saying that, again, sometimes it can be a screen because it's not 100%. It's not 100% guarantee that with her first baby that the blood mixed in a way that caused her to make antibodies. It's not 100% that she makes antibodies, okay, the first time. And so the second pregnancy would be fine, and maybe even the third. So it just depends. It is a possibility. It's not a guarantee. It's a possibility. Right, we take the precautions. That's why they do blood work. That's why they screen. If the doctor and staff are going to be more high alert about this, obviously, if you're in that scenario of you're negative and it's your baby. But they're not going to be that concerned about it with the first pregnancy.
Because you don't have that.
Because your body never seen Rh, so you don't have antibodies. It's only subsequent. So same thing with like me getting a transfusion. Subsequent exposure, second pregnancy, second blood transfusion. That's when it becomes a problem. So again, I'm trying to paint the picture of like this is serious, but it's not like it's 100% guaranteed to happen to everybody all the time, okay? There's a lot of little factors to this. But if this does happen, and again, I've read some articles that attribute a lot of miscarriages to this being not caught in other places where healthcare is not a big deal, okay? And it's a contributing factor. There's so many other contributing factors to miscarriage, though. Body type, size, diet, there's so many contributing factors to a lot of things. So you can't really put one thing equals this. Unfortunately, that's not how medicine works. Medicine is more like magic than it is anything else, unfortunately. It really is because, listen, it's the same thing. You got people that have smoked cigars every day for 70 years and live to be 90. You got people that are 50 that die of cancer and ate healthy and worked out. You know what I'm saying? There is just, the human body is one of those things that's not perfect. We can say this does likely equal this, cause and effect, but, it's not 100%. But that's erythroblastosis fetalis. It is a Rh negative mom being pregnant with an Rh positive baby after the first exposure. And if they've made Rh antibodies, they have the possibility of having this condition of erythroblastosis fetalis, a condition affecting the baby because the antibodies can pass the. So let's just look at this and we'll take a break. But
Classified according to ABO type. Blood is also classified as being Rh positive or Rh negative. Rh positive blood contains the Rh antigen. Rh negative blood lacks this specific antigen. Blood does not normally contain anti-Rh antibodies. However, it is possible for someone with Rh negative blood to develop anti-Rh antibodies. There are two ways this can occur. The first way is when someone with Rh negative blood receives a transfusion of Rh positive blood. The recipient's body interprets the Rh antigen as something foreign and develops antibodies against the Rh antigen to protect itself. If the recipient has a subsequent infusion of Rh positive blood, the anti-Rh antibodies that form during the first transfusion attack the Rh antigen in the donor blood, causing agglutination. The second way someone can develop anti-Rh antibodies is when an Rh negative mother becomes pregnant with an Rh positive fetus. Because maternal and fetal blood does not mix, the first pregnancy with an Rh positive fetus will proceed normally. During delivery or miscarriage, the fetus's blood often mixes with that of the mother, thus introducing Rh antigens into the mother's bloodstream. The mother's body responds by forming anti-Rh antibodies against this foreign substance. If the mother later becomes pregnant with another Rh positive baby, the anti-Rh antibodies can pass through the placenta even if red blood cells cannot. When they do, they will attack the fetal red blood cells, causing agglutination and hemolysis. This will produce severe anemia in the infant, called erythroblastosis fetalis.
clear as mud? Okay, so. Again, go with blood type stuff, go back to antigen is a protein that tells me what the blood cell is. So go back to always, if I'm trying to figure out whatever, go, what's the antigen? They said blood type A, so it is a red blood cell with an A on it. Okay, that means it has the opposite antibodies and go from there, right? If it's a blood type O, it's got no antigen, but it's got both antibodies. Blood type AB, both antigens means I can't have both antibodies. I have no antibodies, okay? So again, think through it that way and then put it all together after that, okay? So blood is our highway. It's full of fluid, right? Mostly plasma. So how do we control that fluid? Well, fluid in our body is in different parts. It's always in different compartments, okay? So that's what they're first telling us about. So most of our body's water. We are mostly water, okay? Most of our body's water is actually what they call intracellular, inside a cell. That makes sense because we have how many cells in our body? Trillions, right? So Most of the water we are made up of a lot of water. Most people are in the neighborhood of 50 to 60% water. Like actually, that's what we are. Water molecules at pure basis. That's why we need water to live, okay? But more of our body's water, they're subjugated into like little compartments, meaning a lot of it's inside the cell, most of it, 65%, or the rest is outside the cell. So 65% of all of our fluid that we are made up of, we're going to find inside cells. 35% we're going to find outside the cell. And they call that inside the cell intracellular, and they call it outside the cell extracellular. So extracellular fluid does have some breaking points of this pie chart, so to speak. Plasma's included that. Why? Because our blood is not inside a cell. There's cells in our blood, right? But that's not intracellular. It's a complex matrix of different stuff. So plasma's included there. What they call interstitial fluid. Interstitial fluid, the name for that, all interstitial fluid is a fluid that's in between tissues. It's kind of the in-between. It's fluid that's in between the cells, but it's not in the blood. It's on its movement path here, okay? It hasn't made it where it's supposed to go yet. So interstitial fluid is a lot of fluid that might end up turning into swelling and edema. We've probably heard of edema before. That usually stems from interstitial fluid. Fluid in between the cells, but this hasn't made it back to the blood vessel, hasn't made it to the lymph yet. And that's where a lot of our fluid comes from. So the principles of fluid go back to stuff we learned of before. Osmosis, diffusion, right? Diffusion is saying particles will try to equal each other out across compartments. Osmosis was saying water will do that if the particles can't cross. Water will try to equal the value out, okay? And so that's a lot of the principles of our fluid balance is where are the particles at? Where are them sodium at? Where's those plasma proteins? Where are they pulling the fluid back and forth? So there's a fast fact down there that's on the first page of 407 that's good to know is that I think it makes sense, but typically a man's body weight is more water compared to a woman's, slightly less, and that just has to do with body type. Men have more blood vessels, usually more muscles. Again, usually, this is statistics. Women tend to have more fat. Sorry, but that has a lot to do with childbirth, okay? That's how a woman's body is designed. That is what it is, right? But I like the contrast they give us in that fast fact. So it's like, okay, men have a little bit more body water compared to women. Think about babies, though. 75% water is what a baby is made out of. They're basically like Osmosis Jones from the movie, okay? They're a water droplet. Babies have like very lean, very little muscle, or very little fat, which means they can't regulate body temperature very well. And that's why we got to wrap them up in the swaddle and put a hat on their head, you know. But they're very lean, okay? They're mostly water. So that's a very distinguishing difference there. So if you kind of flip the page over, page 408, 409, they're talking about the same thing, okay? We've heard this term before, osmolarity. Osmolarity we talked about way forever ago, but osmolarity is talking about how liquid something is, okay? So osmolarity increasing means it's more liquidy, more water. Osmolarity decreasing, it's less water. So water is going to move in and out of cells based on the concentration, usually of electrolytes, like sodium. Salt sucks, right? So water is going to kind of follow salt. So if my tissues in my cells are more salty than the interstitial fluid around it or in the blood plasma, then fluid kind of shifts. It tries to equal that out, okay? That's what's happened. They're talking about that in the body of work at page 408. But the goal of my body for water is homeostasis. Balance it. That's the goal for everything in this chapter. Balance it, okay? So what they're talking about down there on the bottom of 408 is basically the amount of fluid you take in a day should be the amount of fluid that goes out of your body, okay? They should equal, and that's what they're showing you on the, I'm actually going to skip. Is this a question? Yeah, we're skipping that. This right here. The amount, so the subject for fluid balance should be however much fluid I get in should be equal to what I leave out. And that's how equilibrium and balance works, right? So I get water from food actually, from drinking obviously, and I make some water from my cells and other stuff. And I get rid of it actually in breathing. My skin gets rid of it for sweating. A little bit in feces, but a lot of it's going to be in urine, okay? So all I'm trying to get you there is understand that fluid is one of those things that our body's always trying to balance stuff, okay? So you can skip anything on page 409. I'm not going to spend any time on that. That's details about this concept. Just know that whatever you take in, you're going to get out, okay? That's the goal. And if there's an imbalance there somewhere, that's when you get problems, okay? The body is always trying to adjust this intake, okay? So if you drink, right, if I drink 3 gallons of water, what do you think you're going to do more of? Pee. Why? What goes in has to come out, that balance. So keep that in concept in mind. What goes in has to be balanced to come out, okay? I'm actually skipping questions. We're kind of like, you know. So page 410 and 411 talk about disorders of fluid balance and basically fluid being lost or too much fluid. So fluid loss is going to be more in the neighborhood of dehydration. So basically, dehydration is one of those things. I would kind of just define dehydration. Dehydration is when the body eliminates more water than sodium. What does that really mean, though? What that really means is that if you imagine a cell has a certain amount of sodium in it, the blood outside has it, okay? If I lose, okay, more water because maybe I take a pill to help control my blood pressure and it makes me pee a lot. So more fluid is getting emptied out of the bloodstream. This is going to try to equal out, but it can't always do it very well. So that's when I get dehydrated because the water is moving out of my cells to try to fill up the blood vessel, and now my cells shrivel up. They shrivel up, right? You ever seen this? You ever been in the bath too long or in the pool too long? What happens to your hands and your fingers? They shrivel up. That's because the water outside your skin is so vast that now your body's you're moving water in different places to try and compensate for this balance of being in water so much. It's a weird experience. But dehydration is basically I'm losing too much water and salt is taking over and it shrivels everything up. And that's what they're showing you here, basically. Like, oh, I sweat, lose water. The fluid moves out of my blood vessel to fill in the spot where the sweat was. Well, that pulls more fluid out of the interstitial fluid. And that pours more fluid out of the cells eventually until they start to shrivel up. So it's this chain reaction. So dehydration is a movement of water trying to balance it out where we've lost it, but that's going to cause our cells ultimately to be the sufferers of this. And so again, if dehydration is too severe, I can get cell death and damage and stuff like that. That's why you can be so dehydrated, you can cause kidney damage and stuff like that, okay? The cells of the kidneys need constant blood flow, and the cells of the kidneys need their nutrients is just like anybody else. They're eventually going to shrivel up and die, just like anything else. Fluid accumulation, on the other hand, is a little bit more rare. Again, we're going to talk about fluid usually is always compensated by the kidneys. They just produce more urine. So it's very unnormal for us, like water intoxication. I don't know if you ever heard of this. Very hard to do. It's kind of hard to do. Our kidneys usually do a good job of getting rid of that as urine. But fluid accumulation, talked about the bold word on that page is edema. Edema is a need-to-know word. This is fluid accumulation in the interstitial spaces. This is what causes swelling, okay? Edema can be fluid that accumulates in organs. It kind of depends. But typically, if it does an organ, what typically edema is going to affect? Lungs, brain, and then anything in our skin and our peripheral area that's dependent. Dependent like gravity. So hands and feet, right? Dependent on gravity. And then this could go to a lot of things. This could be kidney problems. This could be a lot of reasons why edema happens. But all edema is again, this shift of fluid has come out of the compartment that's my cells and my bloodstream and ended up in the tissues, okay? So let me ask you this. The person with the greatest percentage of body water would be, from that fast fact, who would have the most water, most percentage of their body is dedicated to water? The newborn. Who would be second, though? No, it would be more muscle equals more water. More fat equals less water. This would be number 4, number 3, number 2, number 1, most water. So more fat equals less water, less fat equals way more water. Muscle and less fat equals way more like water percentages. And that's why newborns come out, they're very lean. They don't have like any fat on them, but they can't, remember what fat does for us, conserve body heat, store energy. That's why babies got to eat every 2 hours. You know what I'm saying? Like they have to get energy all the time. They can't keep themselves warm. You got to bundle them up. That's why it has a lot to do with their lack of fat. So electrolytes is the other component of this. There's a bunch of different electrolytes, but you've heard of a few of them already. You've heard of sodium. You've heard of calcium. You've heard of potassium a little bit. But probably your big 3 players in this, all this sort of stuff, is sodium, potassium, and calcium. These guys we're going to talk about. These are related to our acid-base balance, the ones I starred. Hydrogen and what's called bicarb or bicarbonate. We're going to talk about those. But your major ones, the first part of the book talks about, that play roles, again, these electrolytes, sodium, the ones I underlined, sodium, potassium, calcium, play the role in electrical signals, so nervous system impulses, electrical signals in the heart, muscle contraction, right? Blood clotting, all these things, okay? That's their role, those big 3. Muscle contraction, nervous system impulse, blood clotting. Hydrogen and bicarb, or what's called bicarbonate, we'll talk about. They play roles in acid-base balance here at the end, which is kind of the hardest concept out of this chapter to understand. So page 411 does talk about electrolyte balances, and it gives you all the electrolytes and what their normal blood level is. Who cares right now, okay? Don't stress yourself out about that. Yeah, I told you with blood, right? Don't stress about numbers. Know, for blood chapter was know what hematocrit's measuring, know what red blood cell count's measuring, know what hemoglobin's measuring. Don't worry about the number, okay? That'll come later. So I'm going to summarize this pretty easily, okay? I already told you salt sucks, right? So wherever sodium goes, water usually can follow, okay? So the point they're making with sodium is going to determine the volume of water. Where is it going? So if my cells are salty, because I made them mad, just kidding, whatever, I offended them, they're salty, the fluid will follow there to try to equal out, okay? If my bloodstream is really salty, fluid will follow there. Now, this is a rabbit trail, but the rabbit trail is, if this is why you shouldn't have a bunch of added salt when you have problems with high blood pressure. Because all you're doing there is adding more fluid to your blood vessels, which is going to make the pressure higher. So salt sucks water, okay? So wherever salt goes, it's going to kind of determine where fluid is. And most of the time, fluid's in the cell, and it's balanced with what's in the bloodstream and outside the cell. So this is the main electrolyte of extracellular fluid. So extracellular fluid, again, when I look at this, I always think of intracellular fluid, bloodstream, extracellular fluid. Now, there's other compartments in there, right? Like interstitial and maybe what's in lymph, but that's kind of the big 2 categories of what we're talking about here. Mainly what's in the bloodstream fluid-wise and what's inside your cells fluid-wise. And we should have this balance of like basically 65-35-ish. So if salt is higher in one place, guess what? I don't want to carry, the water will follow, right? Too salty this way, water follows. We want it to be balanced. We don't want water shifting around these compartments, okay? So the main electrolyte that's outside your cell, again, the high level is the sodium, okay? Sodium, Na, okay? So on page 412, it goes into this big discussion. Don't stress it. I think it's overall confusing, honestly. The way they laid this out on page 412 is kind of confusing. I wouldn't stress that, okay? Again, summarize it as sodium is the main electrolyte I find outside the cell, extracellular, and I need it for nerve and muscle function, and that's really it, okay? Now, there is a note to make about hormones because guess what? You guys have learned hormones. So you got two hormones that are going to affect sodium. Remember this one? Aldosterone. It's a mineral corticoid produced by the adrenal gland. It tells the kidneys, hey, keep some sodium for me. Save some of that for later. Why? Because sodium helps with fluid balance, right? Salt sucks. So basically, it says, hey, maybe I need to raise some blood pressure, keep the fluid in my blood vessels up. So kidneys keep some, leave it in the blood vessels, leave it in the extracellular fluid. Antidiuretic hormone, also trying to help with fluid balance. It's trying to tell the kidneys to keep some water, so raise water up. Doesn't really affect sodium, but sodium will stay there. So that's all they're kind of telling us. Don't forget that ADH, antidiuretic hormone, and aldosterone affect salt and water levels, okay? Especially aldosterone. Its main point is salt, okay? So again, there's normal value, doesn't matter. I'm moving on already. That's all. I'm summarizing sodium as that. I'm moving from it, okay?
You don't need to know those 2 words, or do we need to know them?
What 2 words?
Hyponutrient.
It's not going to help. It's not going to hurt or help you on your exam. There's only so much you can memorize at this point. But if you learned anything about words, you could figure those words out even if you did see them. Hypo, what's that? Low. Okay. Emia, something in the blood. Nat, that is Na, sodium. The other one to highlight, potassium. It tells it the chief cation, which is just its electrical signal. Electrolytes are electrolytes because they're molecules that either have a positive or negative electrical charge, okay? Like a battery, that's it. Doesn't really, it matters on a molecular, chemistry level, but overall it doesn't really matter too much for you guys. So again, potassium is one of those sidebars that's really important for nerve and muscle function, especially cardiac muscle function, okay? And it's the chief, or the main electrolyte we find intracellular, inside cell, intracellular fluid. So potassium is always going to be a different, higher amount inside the cell than it should be in the bloodstream. So this is why you'll see the difference too if you look at numbers just to see. The number for sodium is like 135 to 145, but a number for potassium, when I draw, remember, I'll get all my information from blood, right? So when I draw a blood sample, your potassium should be somewhere like 3.5 to like 5. You see the difference? Big number difference, right? 3.5 to 5 is a big difference between 135 and 145, is it not? So that means that potassium is one of those things we should find in the cell. When I take a blood sample, I'm not measuring what's in the cell. I'm measuring what's in your bloodstream. So this cell is supposed to be found inside cells, and its movement around helps with electrical signals and those sort of things. But any abnormal value for potassium is going to equal one big thing that people care about the most. This causes issues with the way your heart beats. That's all you need to know, right? I'm supposed to find potassium inside the cell, and if my levels are out of whack, it's going to cause cardiac arrhythmias, which are irregular heartbeats. It's going to cause irregular heartbeats, and which would be considered a medical emergency. So potassium needs to be inside the cell. It needs to stay there. If it gets out in the bloodstream too high, that could cause some imbalances. If I don't have enough in the bloodstream, that means there's probably too much in the cell. That's going to cause more issues, okay? So what a potassium level in the blood tells us is that there's either too much or too little inside the cell because it's either spilling out into the bloodstream or a bloodstream level is too low. Because remember, it's a balance. It's supposed to be a certain way. If it's too far one way or the other, it's going to cause issues, okay? So I wouldn't be scared of what it... Only thing I would note about this is, again, sodium problems, what do? Muscle function, nerve impulses. Potassium problems, what does it do? Muscle function, nerve impulses. Specifically, potassium is really key for our ability for the heart to pump and pump effectively at a right rhythm. remember a normal sinus rhythm at this nice, solid rhythm. Potassium gets out of whack, it messes with that rhythm. Okay, we all right so far? Okay. No? Okay, fair enough. Again, calcium, just as a sidebar, I've been saying this the whole time. Calcium, I'm not going to talk about, we already talked about hypo and hypercalcemia before with calcium regulation. Remember the thyroid, parathyroid play that role? Calcium, muscle contraction, nerve transmission, nerve impulses, blood clotting. We just talked about that. That's all I need to say about calcium. Again, who cares about the numbers? I don't care. Calcium is one of those ones that is usually a little bit lower in the blood, more inside the cell. But this makes sense if you think about it because calcium was in all of our muscles, just sits there and then moves, right, to block so the sliding filament model happens, okay? What? You all have access to PowerPoint, so. Again, I could also do no PowerPoint. And also, you had all weekend to look at this stuff. So if you're like, I can't believe there's a second, I don't care. How about that? How about that one? Don't care. I ain't playing no games anymore. Y'all, we literally like 8 weeks in. Come on. There's nothing new here. I'm saying. That's it for, so there's fluid balance as a whole. Fluid balance is a lot of sodium affects it, and I need to have however much I take in should be how much I get out. Electrolytes is main ones, sodium, potassium, calcium. Pretty much all of them important for muscle function and nerve impulse. Potassium, much more important for cardiac impulse, so it's bad if it's out of whack. Calcium helps us with blood clotting. That's its only secondary option. But either way, they're out of whack. And the main electrolyte I find outside the cell, sodium. Main electrolyte I find inside the cell, potassium. Done. Just summarize all of it for you. That's it. So the last part of this is acid-base balance, which is going to take a second. And we're running. We got 20 minutes. All right. So overall, what this acid-base stuff is talking about, this starts talking on page 414, okay? Keep it really simple. It's another homeostasis. If I'm too acidic, okay, I die. If I'm too what they call basic, okay, not your basic girl, all right, but if I'm too basic, if I'm too basic, then I'm too far the other scale, okay? And it's a scale they made up, okay? It's a confusing scale, but I didn't make the scale up, okay? I didn't do it. It's not my fault, all right? It is what it is. Let me pull this over real quick. Where'd this window just go? Come here. So acid-base balance is all this thing called the pH scale. pH, P with an uppercase H. The H stands for hydrogen. I mentioned that. So hydrogen is one of kind of these chemicals we make. It's usually in the family of CO2. It's a byproduct. Hydrogen is a molecule. It's a byproduct of our cellular metabolism. And what pH is a scale is all it does is measure hydrogen levels. And so for human beings, we are supposed to be in a range of, when we check blood pH, 7.35 to 7.45. I'm going to show you the scale in a second. The goal of the pH scale is just to tell us where we are. That's where we're supposed to be. Anything outside of that is a whole nother can of worms. It's not really anything that you're going to find us measured on, okay? So to give you some context of like what is the pH scale. Oh, will you stop it? Why did you do that? I hate my life. What is happening here? You get down here. Get in my way. There.
Does hydrogen help with balancing everything out?
Hydrogen, hold on. So pH scale, hydrogen ions. What hydrogen is an acid. Hydrogen is an acidic molecule, okay? So hydrogen, however much I have, equals acid. And it's a byproduct, okay? When my muscles contract, when my cells make ATP, I'm going to make hydrogen. And I need to get rid of it. So the goal most of the time of our body is getting rid of hydrogen. That's the goal. We make hydrogen as a byproduct of all the normal stuff we do, especially in our cells. And the goal is to get rid of it. So typically, most people become more acidic other than the other way because we're always making stuff that's acidic. And so we're trying to balance that out. So when balances happen, it's usually going to be more acidic. But if you see where we fit in the scale, we fit in the scale between water and blood. That's where we fit, right? That's where we fit. Everything else is irrelevant to us, but if you're trying to get an idea, hydrochloric acid and stomach acid, very much the same, okay? Hydrochloric acid is something you do when you're trying to hide a body, all right? I'm just kidding. I mean, it's true. But that will literally eat flesh and bone and just disintegrate anything, okay? It's what the alien's blood's made out of. All right, so things that are different. Lemons, vinegar, much more acidic, right? And you can tell that, right? You eat a lemon, it's very sour, tart. Going other way is what they call basic, or they call this alkaline. So you go all the way to like sodas kind of this way, milk, all the way into soap territory. And then things like bleach and drain cleaner are actually very alkaline. But here's the thing. What do drain and bleach cleaner have in common with stomach acid, you think? It's going to burn and destroy stuff either way. So what that tells us basically is that when things are so far outside of pH scale, whether they're super alkaline or super acidic, they're destructive, okay? Either way, they're going to corrode and destroy things. Again, bleach and drain cleaner are usually helpful, right? They clean the drain out, they clean the shirt. Stomach acid, very helpful. You know, helps us digest food, but it's corrosive and destruction. And our whole body can't live there. It's got to live right in the middle of this scale, okay? So we live at 7.35 to 7.45 on the pH scale. This is the pH scale. It's just a relative scale to say the more this is going to throw everybody off, but stay with me. The more hydrogen I have, the more of this I have, hydrogen ions, the more I have. Because hydrogen is an acid, the more acidic I get, the number gets lower, okay? That's what's happening here. So the super acidic here, okay, is stomach acid, real low on the scale. The higher I get, the less hydrogen I have, likely the more basic molecules I have. Again, it still gets corrosive, so we have to live in the middle, okay? We live in the middle. So variations of this outside of 7, so if I'm 7.2 pH, I am very acidic on the scale, and about 7.1, I'm dead, okay? The lowest I've ever seen is like 7.19 or something, and they were in a coma, all right? They're small variations, okay? We operate on this, and most every day, none of you will ever experience any problem with this because our body's very good at getting rid of hydrogen. That's the goal. We make hydrogen from like everything our body does, and so the goal is let's get rid of it, okay? Of course, we keep some of it for things we need, like our stomach acid, but overall, it's usually in a spot we're trying to get rid of. So that's the pH scale. Again, more acidic means I have more hydrogen ions. The number gets technically lower. Less hydrogen ions, usually I'm getting higher on the scale, pH. But most of our variations are always, always, always going to be too much hydrogen ions, which means my pH is getting lower. So typically if people have an acid-base balancing problem in a hospital setting, they're going to be 7.25, 7.27, 7.3. They're going that way on the scale because they have more of this hydrogen on, okay? So, yeah.
Sorry, I always have like the sex questions, guys. But just
Okay.
when it comes to like when people say, "Oh, like that threw off my pH balance."
Talking about like in the vagina?
Yeah. Like what is that?
So I don't, well, okay.
You say, okay, more hydrogen is acidic base.
So the easiest way to summarize that is that how am I saying that?
It's sensitive.
I mean, well, there's also bacteria in your vagina. Sorry. It'd be them. All right. Yeah, it can be anything. Like, it can be the food you eat. It can be that sort of stuff. Yeah, it can be the food you eat. What kind of body wash you would use, because of course that place is getting cleaned, and some of it's going to go into the vagina canal, and it's going to mess with the pH balance. Same thing with your mouth. Okay, some antibiotics and other stuff are going to mess with the pH, the acidity of your mouth, and you could get fungi in your mouth and stuff like that. It's the same concept, okay? You have, every part of our body has natural flora, a natural bacteria, okay? So vagina, the rectum and all the GI tract, your mouth, nose, all has normal bacteria that hangs out there. And if I mess with that, kill all that off, or do something that changes it, could cause fungal infections, could cause other infections, that sort of stuff. So that's what they're talking about. Okay, yeah, what? That's how C. diff comes about. C. diff comes from, I kill all other bacteria. C. diff says, sweet, I got home to colonize, and now I'm colonized. And C. diff's normally found in everybody's intestines, yes.
So all those people that buy like balanced water, like pH balanced water, are really just wasting your money.
Yeah, I mean, probably. Does it help? I don't know, probably, but statistically.
And then the alkaline water and all that stuff.
Yeah, the alkaline water is pretty much a scam, yeah, but. It depends on what you get out of it. If you're looking for a magic, like, get healthy thing, it's not that, but I mean, if you're trying to make better decisions about what you drink, yeah, but.
Like for my work, I have to go buy things sometimes.
Yeah.
More than a few of them are like, oh, this alkaline water makes me healthier.
That's a placebo effect, but does it actually make them healthier? Yeah. Could they actually feel it? Probably not. All right, let's reel it back in. We don't have much time. Let's reel it back in. Okay, so look at, all right. So here's the theme with pH. Listen to me, I'm telling you. Here's the theme with pH. pH is basically, the problem for us is we make too much hydrogen. All our byproduct is we make too much hydrogen. So our goal, oh, that's somebody shaking their leg. I thought it was like music playing. No, someone was shaking their leg and the desk was doing like the anyway. I thought someone had a beat playing. That's what I know. So the goal is to get rid of the hydrogen, get rid of this H molecule. Hydrogen needs to get balanced out. So most of our body systems are all about, let's get rid of it, okay? So page 415, if you jump over and look at it, it talks about buffers, okay? Buffer systems. So we have different systems that try to buffer this. Like, oh, hydrogen on, get rid of it. Let's keep the pH balance right in the middle where we want it. So they include a few different ones. Doesn't really matter. All you need to think of is there's basically three. This is number one, chemical buffers. We have chemicals in our body. One of them, the main guy, being this guy called bicarbonate, which is more basic or alkaline. Okay, I can't write. I'm going too fast, but that's what it is. This guy will basically, hey, come here, hydrogen ion, grab the thing up and help get rid of it. Maybe it'll go out in our digestive tract. Maybe it'll end up dumping out in the kidney, but for now, a lot of times, it's going to grab this chemical up and get the hydrogen out of our bloodstream, get it out of our system, and that just drops our acidity, okay? They bind with the hydrogen ions to basically change them. So I know a lot of people may have not had chemistry at all or barely remember chemistry, but when chemicals typically bind together, they become a new chemical. And so what bicarb and other chemicals are doing is saying hydrogen by itself, bad. Hydrogen by itself makes us more acidic. We don't like that. But if I grab hydrogen, I can make a new chemical, and it hides it. It hides the acidity of it. It changes the chemical compound. That's what chemical buffers do. And they are the first kind of line of defense, the first guy to get involved. As soon as our hydrogen ions are so enough in our blood that it might change our pH, chemical buffers are just grabbing those bad boys up and changing them chemically, and that makes us less acidic. And so it keeps it balanced that way. You never feel this. There's no symptom involved. There's nothing that you would ever know about this happening. That's chemical buffers. Now there's a formula they give down there, and I'll show this in a second, but don't stress about the formula, okay? Don't stress about the formula in 415. Just don't stress. Don't stress about it, okay? Turn the page to 416. 416 says we have some physiological buffers. So number 1 is chemical buffers. Number 2, physiological buffers with 2 of them, basically. So these, you might feel some symptoms when they get involved. Man. So we have our respiratory system, and we have our urinary system, aka the kidneys. So our lungs, okay, they get CO2. CO2 is a combination of hydrogen ions. Basically what CO2 is what they call, you take carbonic acid, the liquid form of hydrogen and carbon, and you make CO2 into a gas form. And our lungs will get rid of it. So if I'm breathing, what I'm doing is expelling CO2. What's going with it? Hydrogen ions. CO2 and hydrogen love each other very much, okay? And so CO2 will grab it, make a new molecule, and we are able to expel that out of our lungs. So anytime you think CO2, think that CO2 is carrying hydrogen with it, which would increase our acidity, make us more acid, which would do what to that pH on the scale, though? Decrease it. Make it like 7.3, 7.27, whatever. Go down the scale. So anywhere there's hydrogen, the pH scale measures hydrogen, and they made it dumb because they're scientists. And the lower the pH, the more acidic something is. So carbon dioxide that we're trying to get rid of is binding with hydrogen, and it makes it more acidic. So as long as we can keep getting that out of our lungs, we're in good shape. But when my lungs get involved, it's gone past chemical buffers, and that's a little bit more taxing on us, okay? The last one is the kidneys. And the kidneys, basically, it talks about it on page 417. The kidneys of the buffer system, they just expel hydrogen to lower the pH. The kidneys straight up just grab hydrogen and get rid of it, okay? And that helps to lower our body's balance, our pH balance. So it talks about that on the page 417. There's a little thing that says that makes sense, and it talks about cells constantly produce CO2 as a byproduct. CO2 reacts with hydrogen, and the body is trying to get rid of it. So we can chemically bind with the acid, hydrogen. There's the chemical buffers. We can chemically bind with it, and that hides the hydrogen, thus making our pH better. Or we can expel it by combining it with CO2, get rid of it out of our lungs, or our kidneys can get rid of it. If you look over the body of work on page 416, it does mention the timing of all this. Chemical buffers happen in seconds. They're happening all the time. You would never know it. If for some reason my acidity level rised, my lungs could breathe a little faster, I'd expel more CO2, thus getting rid of more hydrogen, leveling out my acid-base balance. And then finally, it takes days or hours, probably hours, for my kidneys to get involved. If my kidneys are getting involved, they're really trying, it's a challenge here. They're really working hard, okay?
So, the body at work on 416, is that a new term?
Yeah. I mean, it's just helped make sense of it too. So chemical buffers are going to be in play first, then physiological, then respiratory. Physiological just means it's either respiratory and urinary. Usually they go in that order though. Like first, again, think about it, okay? If you take off running, okay, what's the first thing that happens?
Your heart rate gets faster.
Your heart rate gets faster, yeah, but what else do? You're breathing, you just generated more acid because your cells did more work. Your muscles contracted more. You did all this more work. You made more acid, and you got to get rid of it. And at that point, your chemical buffers are a little bit overwhelmed, so your lungs kick in and breathe a little faster. Now you'll probably pee some of that acid out, but that's not going to happen immediately. That's a weird condition. You need to call someone about that. If you just pee while running, but that's going to happen later. So what does this look like practically on a person? Okay, let's do this. Acid-base imbalances, okay? This is page 418. This is where you put that all together, basically. Page 418 talks about the imbalances. We don't want to be towards one way or the other, okay? So basically they're telling us that if an imbalance can be defined basically as a respiratory imbalance or a metabolic, okay? And so the two players in here really is, yes, hydrogen, hydrogen, hydrogen. But I mentioned it already. We've got a guy so that's hydrogen, always going to make me more acidic. This guy is bicarb, who's always going to make me more, bicarb is more basic or alkaline. Bicarb basic, hydrogen acidic. And these guys are always in a little fight match in our body, trying to help us keep the balance. Again, our body always makes more acid. We're always fighting the acidity, but bicarb is there. So everything that's an acidic-based kind of imbalance is going to be that. But everything can be categorized as either some kind of what they call acidosis or alkalosis, and it's got to be respiratory or metabolic. And here's a hint with this. Again, I'm teaching this now so you'll have it later, but the hint with this is if somebody said nothing about the lungs, it can't be respiratory related. You see what I'm saying? If a problem persists where someone's giving you a patient and there's nothing wrong with their lungs, well, it's probably not a respiratory imbalance. It's probably something metabolic. Metabolic means everything else. GI and the kidney issues, that sort of stuff. So look at that chart. Let's talk about it. Let's put it together. It's basically this chart here. Basically, for the most part. Well, not this one. Not this one. Whoops. This one's way too... Well, this one works. Okay, so... It's saying basically what's causing my acid gain. The acid gain, meaning more acidic, acidosis. I'm losing too much acid. I'm becoming more basic. That's alkalosis. That's the pH scale. Bleach and all that stuff, really high number on the pH scale, is alkalosis, okay? Alkalosis is what they call that because it's alkaline. So if I'm somebody that has a respiratory disease and my CO2 is going up, remember CO2 and hydrogen love each other. If I have too much CO2 in my blood, that means I'm likely to have too much hydrogen, and that makes me more acidic. So if someone has sleep apnea, pneumonia, the chronic lung diseases, emphysema, bronchitis, they could be at risk for respiratory acidosis. Loss of carbon dioxide, meaning I'm getting rid of too much carbon dioxide. Is that a thing? It sure is. Hyperventilating. Have you ever seen a movie where someone's freaking out and they're hyperventilating, like an old school movie, and they give them a brown paper bag to breathe into? Why are they doing that? That captures the CO2 and they breathe it right back in because they're losing it. So they're getting more basic. Their CO2 levels are going down. And I said CO2 is, again, friendship and lovey-dovey with hydrogen. So the balance is always with this stuff is hydrogen and bicarb have to have a balance. Bicarb is HCO3. They have to be in a balance. So this side is saying respiratory acidosis is saying I got too much of this. Respiratory alkalosis is saying I'm losing too much of this. Bicarb never changed. I'm just losing too much. So the balance is out of whack. I'm more basic. I'm leaning that way. And that can cause symptoms of, again, neurological issues, brain shutdown, coma, dead, if it got too far. Usually people would pass out before that happens. Hyperventilating will make you pass out. And then when they pass out, they'll breathe normal. Their medulla will take over. But not a good thing. So metabolic acid, it means I have to gain some acid, become more acidic than normal. So increased production of acids. This could be something like, again, too much working your muscles, producing lactic acid, something called DKA, diabetic ketoacidosis, is when I'm so high on my blood sugar, it starts producing these things called ketones. So metabolic was basically the way to summarize this. If it says nothing about the lungs, it's got to be a metabolic disorder, okay? If it says nothing about the lungs, it has to be metabolic. I take too many acidic drugs. My kidneys fail. They help get rid of hydrogen. If the kidneys don't work, hydrogen goes up. Therefore, okay, chronic high levels of hydrogen. The other side is if I'm losing hydrogen usually. Metabolic alkalosis is always rare, but if I'm losing hydrogen, I'm losing the balance. So if I'm severe vomiting, I'm vomiting what up? Stomach acid. That's part of my regulation of my acidity. I'm losing acid now. Someone puts a suction tube down my nose and suctions my stomach out of all the gastric juices. Now I don't have any hydrogen ions where they're supposed to be. Losing hydrogen ions. I take a bunch of Tums, which are bicarbonate. Well, you know what Tums is? It's calcium bicarbonate. Because it's trying to reduce the acidity of my stomach so my GERD doesn't feel as bad. I've seen someone, the only time I've ever seen metabolic alkalosis in my entire practice was a lady who was over abusing Tums. That's the only time I've ever seen it.